Hello, my name is Donovan Straczynski. I'm a hack nursing student, and today we'll be going over enema and ostomy validations. First, I will start with enema. First, I'll state my first five, which would be hand hygiene, identify the patient, review allergies, provide the patient privacy, and educate the patient on what I'm going to do. The next step for doing this would be performing a bowel examination, which first I would use inspection and look at the abdomen, look for distension, position of the umbilicus, um, and any lumps or protrusions. Then I would go to auscultation and I would listen to the bowels. I would start in the right lower quadrant and move up to the right upper, then the left upper, and then the left lower. And I would be listening for bowel sounds which could indicate peristalsis. And I should listen if I hear no bowel sounds for a duration of 5 minutes. And if I hear bowel sounds, about 15 to 30 seconds after you hear the bowel sounds, just to kind of confirm that they're going. And then I would proceed to set my enema up. I would go over diagnosis, orders, notes, allergies, and protocol. I would go in, I would identify, introduce myself, explain what I'm doing, go over allergies, lock the bed, elevate that bed, and sanitize. Then I would take my enema, which would be this. In a sense, this would be the bag and this would be the tube. I would fill this with about 1,000 mLs of water because that's what the order calls for. Then I would position my patient appropriately. I would have them lay on the left side with their right leg up. And this just promotes the flow going into the colon because of anatomy. So then I would make sure my tubing is lubed. I understand some of them or a lot of them are already pre-lubed, but if not, I would just have to lube the tip appropriately just so it slides in for the comfort of the patient. I would advance the tube into the anal canal, holding it because I understand it wants to push back out as you're trying to insert it. As far as the internal anal sphincter, if the patient is sensitive to this, I would just tell them to take a deep breath and release as I go through, and I understand this really helps as well. After I would insert it about 2 to 4 inches in the patient. I would maintain the bag level. If it's too high, they may be uncomfortable because it's rushing in. I would try to keep it about 10 to 12 inches above the patient's head just for optimal flow. I would then take the tube out. I would get the patient comfortable. I would tell them to hold it in as long as they possibly can, ideally 30 minutes or more. And then provide like a bedside pan or commode for the patient, just in case. Then I would appropriately dispose of this. I would take my gloves. I would take them off as instructed in the video, tape them so they cover the end of it, and I would dispose of this in the receptacle. Then I would appropriately document the procedure, which I will provide. Also, I have this little dummy I forgot to show. You'll see on my couch. I would have the patient laying this way. This would be my left side, and exposing the anus, and I would insert it as far as here. It's a little penguin. Okay, so next I'm moving on to the ostomy portion of this validation. I would obviously state my first five as previously, go over all of the previous stuff, diagnosis, orders, notes, allergies, and protocol. I would then drain. I would unclamp the pouch. I don't have one here to show, so I'll use this. I would unclamp the pouch at the bottom, have something to collect the waste in, and I would have it open and I would let it drain. Kind of squeeze out the majority of it, just kind of let it run into the receptacle. Then I have like a washcloth I would use, like damp washcloth, and I would clean the inside of the bag. I would then place the clamp and secure the bag appropriately again. So clamp it how it was, like that. Then I would proceed to change the bag. So first I would have to take off the bag and the wafer. The wafer would be stuck to the patient's skin. I would have to be gentle and careful when removing this. It may be a little tacky. So I would take that off. I would clean around I would cleanse the skin. I would dry the stoma. I would do an assessment on if I see any signs of inflammation, infection, swelling, drainage, anything like that. I would assess any abnormality. Then I would accurately measure the stoma with a template provided. It has different sizes with circles. I would gauge the size of the stoma with the closest circle, and then I would draw it. And I have a little fake stoma here that I'm going to back this up. So this is the fake stoma here, and I drew the circle around it here of what I thought it was. So what I would do is cut from the inside. I would kind of cut around to create my hole. Okay. So I have this here. I would want the hole I cut out to about a quarter of an inch away from the stoma, and so this does look like it is about a quarter of the inch, a give around the end of the stoma, so it looks like a good size that I had cut out. So from here, so then obviously after I have that dressing done, I would apply it to the site, tack it on, and just make sure I have that quarter-inch border around the stoma. And then I would accurately document my findings and what I had done. So those would be my validations for enema and ostomy, and I will be providing the documentation along with the video in addition to both. Thank you.